Hello, thank you for joining me in today's webinar, Taking a Deep Cleansing Breath, Updates in the Management of Chronic Sinusitis with Nasal Polyps, sponsored by Integrity Continuing Education. My name is Joseph Hahn. I'm a professor in the Department of Otolaryngology, Head and Neck Surgery. I'm the chief for the Division of Rhinology and Endoscopic Sinus and Skull-Base Surgery, also the chief for the Division of Allergy at Eastern Virginia Medical School, which is located in Norfolk, Virginia. Here are a list of my disclosures. So the learning objective tonight is to analyze the phenotype and endotypes of chronic rhinosinusitis with and without nasal polyps, and understand what we have developed so far in terms of the immunologic pathophysiology and its impact on disease burden. We're also going to summarize the mechanism of action for the new and emerging targeted biologic for chronic sinusitis with nasal polyps. We're going to look at the efficacy and the safety profile using the pivotal clinical trials information. We're also going to implement a shared decision-making tool and talk about that and how we incorporate that in treating our patients with nasal polyposis and determine whether or not biologic surgery or other treatment is appropriate for these patients with nasal polyps. So let's start off by starting off with a pre-test polling. So here's the question. The primary cytokines involved in type 2 inflammation, the most common endotype in patients with chronic sinusitis with nasal polyps are number 1, interferon gamma IL-2 and IL-12, TNF with IL-6, IL-4, IL-13, and IL-5, or IL-17 and IL-2. So after you submit the question, please select the submit button on below. Let's go to the next question. So which biologic showed an improvement in nasal polyp score equal to or greater than 2 points in close to half the patient population at week 24 and week 52? One choice is benralizumab, the other choice is dupilumab, the other choice is mepolizumab, and the last choice is omalizumab. So please, after you pick the choice, please select the button Submit on the bottom. Okay, let's go to the next question. What is the most commonly observed treatment adverse event across the clinical trials of all biologics studied for chronic sinusitis with nasal polyp? Is it epistaxis, injection site reaction, nasal pharyngitis, or abdominal pain? So after you pick your choice, please select the Submit button on the bottom. Okay, let's go to the next question. So here's a little bit of a case scenario. Mr. Brown, a 42-year-old patient with the severe chronic sinusitis with nasal polyp, returns 12 months after endoscopic sinus surgery, complaining of persistent symptoms. You suspect that nasal polyps have regrown, as a type 2 inflammation is a predictor of polyp return in greater than 50% of the cases. So the disease scoring systems show some improvement, but do not meet the Euphoria criteria for adequate response. So what does the Euphoria recommend now? So if they don't get better with medical treatment, what should you do next based on the Euphoria Guideline? One is return to medical management and short course of oral steroids, biologic or revision sinus surgery, exhalation delivery system with fluticasone, corticosteroid eluting steroid implant. So please pick your choice and Okay, and this is our last question. So, feeling discouraged, Mr. Brown says that if the polyps are going to grow back anyway, he doesn't want to go through the expense, pain, and downtime of undergoing sinus surgery. So, you talk about shared decision making. What does that mean? So, shared decision making means the best action would now be one, advise him to consider sinus surgery because 30% of patients do require repeat surgery. Apprise him that guidelines recommend and ask him to decide between two treatment options. Give him the information of all the available biological and ask him to choose one, or let him know all the therapeutic options and the pros and cons of each. So I'll pick your answer and then please select the submit button. All right, thank you. So let's start off with a case presentation. So this is Bob. He's a 45-year-old male with a history of chronic sinusitis with nasal polyp. He has comorbid asthma, which is not unusual. The patient has polyps and he's had it for the last 2 years. He's been treating his sinusitis with nasal polyps with recurrent use of systemic steroids within the last 2 months. He's also using daily treatments of saline irrigation and nasal steroid spray. And despite this, the patient continues to have persistent symptoms. He states that his sleep quality is affected, his work productivity is affected, and his social life is negatively affected, which is consistent with the patients that we see with nasal polyps. He's never had sinus surgery. So now at this point, if this patient comes to our office, which is a typical patient with nasal polyp, what additional information would you want to consider at this point? Would you want to consider looking at eosinophils and total IgE, get a CT scan of the sinuses and nasal endoscopy, spirometry, and pheno? And I think this patient, this 45-year-old male with nasal polyp, it sounds like his sinusitis with nasal polyp is not well controlled. So you kind of want to start endotyping them. So what is clinically available is the blood eosinophils and total IgE. So I don't think that's not an unreasonable option. Certainly getting a CT scan and nasal endoscopy are things that I would certainly consider to kind of objectively measure. And I would hold off on getting a CT scan after a medical treatment. And certainly consider that. But on that initial visit, I would do a nasal endoscopy. Certainly with him having comorbid asthma, you want to consider whether or not his asthma is under good control, so you can do spirometry and pheno as well. So I think these are all reasonable choices. So let's shift gear a little bit and talk about chronic sinusitis. So it is actually a very common chronic disease. It affects about 29 million people according to the CDC. That means about 12% of the general population have chronic sinusitis. And chronic sinusitis is broken up by the phenotype of the presence of nasal polyp. So chronic sinusitis with nasal polyp, as detected by nasal endoscopy or anterior rhinoscopy, is about 20%. And majority of patients do not have nasal polyp. And when we look at the prevalence of chronic sinusitis in the world, we see that it is different depending on which country you live in. So in Europe and the US, they have higher percentage of patients with chronic sinusitis, while in other countries are a little bit lower, like Canada and Brazil. And what's also interesting is the prevalence of chronic sinusitis with nasal polyp is also different. It tends to be a little bit higher in the US and in Europe, and a little bit less in Asian countries like China and Korea. Although you do see the increasing percentages of chronic sinusitis with nasal polyp increasing over the last few decades in the Asian countries. So when you look at how chronic sinusitis impacts our healthcare system, this was an observational study from a large claim database. And when they matched about 11,000 patients with nasal polyps compared to those without and kind of matched them by gender and age, you see that the patients with nasal polyp have significantly higher burden of medical costs. So about a little bit over 11,000. And the cost of between the patients with nasal polyps and without is higher across the board, whether it be with drug use or medical costs, office use, or ambulatory costs, which likely includes surgery. So how do you define a patient with chronic sinusitis? So, I mean, this was from the ICAR in 2016, but this has been around since not in the 1980s, over 30 years. And the best way to decide whether or not a patient has chronic sinusitis is based on symptoms. And the most common symptoms are drainage, nasal congestion, facial pressure, and decreased sense of smell. And then if they have these symptoms, the more of these symptoms that they have, the more likely they're likely to have a positive CT scan for sinus opacification. But certainly, even if they have these symptoms, you want to make sure that there are objective evidence of sinusitis, whether it be with a nasal endoscopy or CT scan. And so when we split up chronic sinusitis with and without polyps, we see that the ones without nasal polyp tend to more likely have facial pressure and pain, while chronic sinusitis with nasal polyp tend to have symptoms of loss of smell or decreased sense of smell. And there are two CT scans on the top. You see the left CT scan is a normal CT scan, while the one on the right has severe sinusitis because you can see opacification of all the sinuses, most likely having pansinusitis. If you look at the two images on the bottom, this is a nasal endoscopy on the right side, showing the middle turbinate and inferior turbinate and the septum being normal. And you can see on the right side, on the right image, you can see the nasal endoscopy showing nasal polyp, and you can see that it's medial to the inferior turbinate emanating from the osteomedial complex. Now, one of the things that we do have to decide is how do we define chronic sinusitis or the severity of it, or whether or not it's controlled or not. And that's something that the Euphoria has recently published. I was fortunate to be one of the authors. And the way we kind of decide, whether or not chronic sinusitis is uncontrolled is that if the patient has persistent or recurrent disease with nasal polyp despite being a long-term medical treatment and requiring use of systemic steroids in a period of a 2-year process or sinus surgery. So that's how we define uncontrolled. So meaning that despite medical treatment, it's just not able to control the symptoms, which is a little bit different than a severe chronic sinusitis. So the way we define severe chronic sinusitis is if the polyps are very large, so greater than a nasal polyp score of 2, that means that the polyps roughly are extending below the inferior border of the middle turbinate despite medical treatment. So those are severe patients. Now, it's not surprising that patients with nasal polyps have other comorbidity. So by definition, if someone has ARD or NSAID, you have to have asthma and nasal polyps together. We see that asthma is very common and occurs to almost 2/3 of the patients with nasal polyps compared to those without. So without nasal polyp, the percentage of asthma tends to be a little bit lower. Allergic rhinitis, according to this paper, is about 50%, but you can see that allergic rhinitis can be as high as 70 to 80% in patients with nasal polyps. But certainly ARD, asthma, and allergic rhinitis tend to be associated with nasal polyps. And not only is asthma and nasal polyp associated together, but the nasal polyp seems to predict that the asthma is more difficult to control and they're more likely to have a higher exacerbation. And if you compare patients with asthma, whether or not they have polyps or not, you can see that they have higher blood eosinophils. You can see that they require increased use of steroids and that the asthma control system is higher. Is lower and less controlled. And if you look on the right table, you can see that the percentage of number of acute exacerbations for their asthma. And you can see that the presence of nasal polyp tends to show that it has higher acute exacerbations for their asthma. Now, when we talk about ARD and nasal polyp, what do we mean? We know that they're higher in patients with asthma, and nasal polyps tend to be related. They tend to be driven by cystinoid leukotriene receptors. So if you measure their urine LTE4, it tends to be higher. These patients tend to tolerate COX-2 inhibition, and these are some of the most difficult patients to treat. So what drives these inflammation? And we know that there are three types of inflammatory endotypes that have been described in chronic sinusitis with nasal polyp. I think type 2 is the one that's most well defined in chronic sinusitis, especially if you have nasal polyp. And when we say type 2 inflammation, these are driven by type Th2 cells, ILC2 cells. They tend to have eosinophils, basophils, and mast cells. And when we look at the inflammatory cytokines, they are IL-4, IL-5, and IL-13. And so these inflammatory cytokines are very much associated with type 2 inflammation, especially seen in nasal polyps. Now, type 1 and type 3 are also other types of inflammatory cytokine, not as well defined in chronic sinusitis, but for type 1, the inflammatory cytokine is interferon gamma and IL-17, while for type 3, they tend to be driven by Th17 cells and IL-17. And historically in the past, when we talked about chronic sinusitis without nasal polyp, we historically had called them Th1 inflammation, and these patients, again, has less asthma and allergic rhinitis, while chronic sinusitis with nasal polyp have historically been described as Th2 inflammation. And again, these patients tend to have more type 2 inflammation, such as asthma, allergic rhinitis, and ARD. When we talk about type 2 cytokines, as we mentioned earlier, the predominant cytokines are IL-4, IL-5, and IL-13. And we know these are the prominent players in our patients with nasal polyp. So how does this inflammation occur? And the inflammation occurs by some type of activation in the epithelium. And it doesn't matter if it's allergen, virus, or bacteria. It incites a release of the epithelial alarmins, such as TSLP, IL-25, and IL-33. And in the allergic pathway, you see that IL-4 to IL-13 affects the B cells, causes class switching, which then makes memory cells, then release of IgE, which affects the basophils and mast cells. We know that IL-5 is closely related to eosinophils, and IL-13 is responsible for the migration of the eosinophils into the tissue. And IL-13 is also responsible for globulate hypoplasia and secretion of mucus, as well as collagen deposition that we see in our patients with nasal polyp. So we see that IL-4, IL-5, and IL-13 play a key role in our patients with nasal polyp. So going back to our patient, Bob, we see that he has comorbid asthma as we would expect. When we check this FEV, you see that his asthma is not well controlled by his FEV1 and reversibility of 17%. We see that with his FeNO is above 25, so it's also not controlled. So despite being on ICS and LABA, his asthma is not well controlled. And despite treatments with nasal saline irrigation and topical steroids. So what would you do for Bob? Would you consider doing sinus surgery, biologic treatment, exhalation delivery system, or alternate use of steroids? And I think, these are all reasonable options. But let's look at this a little bit further in the next section. So let's talk about medical management. So we know that the standard of care is using saline irrigation as well as topical steroid spray, but we know that they're not very effective. A lot of these patients with nasal polyp with saline irrigation nasal steroid spray just don't get better. In fact, majority of them fail. And so that developed other treatment options for nasal polyps. So one of them was the exhalation delivery system. And if you look at one of the pivotal studies, Navigate 2 study, you see that when this exhalation delivery system was used, you saw that there was a reduction in the polyp size and the patient symptoms of congestion. We know that about 25% of the patient had reduction of nasal polyp on of at week 24 compared to the placebo, which had less reduction of or elimination of nasal polyp. We saw that the SNOT-22 had a reduction of 21 from baseline, and so that's twice that of the MCID. Another treatment for nasal polyp is performing sinus surgery. We know that sinus surgery provides immediate relief of the symptoms, and the success rate is pretty good. But if you have nasal polyp, it's likely that the polyps will continue to regrow. In a very nice study in looking at patients with nasal polyp, if they have sinus surgery and appropriate medical treatment afterwards, 40% of the patient had regrowth of their nasal polyp in 18 months. And so what we often tell our patients with sinusitis with nasal polyp is that, you have sinusitis for the rest of your life. You have a nasal polyp, you're going to have it for the rest of your life. And so this was a study from Galen, which is a group of European physicians. And when they looked at patients with nasal polyps, they were given initial treatment with nasal saline irrigation, intranasal steroid spray, and short-term use of oral steroids. And we see that 46% of these patients, despite the initial treatment and appropriate medical treatment, about 46% of them required surgery. And when we looked at the 46% of the patients who had sinus surgery, we see that about a third of these patients had polyps regrow at 6 months. And so that's a lot of patients that have regrowth of the nasal polyp. So there's got to be better treatment options that are available. Another treatment options that is available in the US, if you have recurrence of nasal polyps after sinus surgery, are the steroid-eluting stents or implants. These are only approved in adult patients who have undergone sinus surgery, specifically ethmoid sinus surgery. And these steroid sinus implants deliver mebendazole over a period of 3 months. And this actually can be performed in the office. So this is based on phase 3 study, Resolve 1 and Resolve 2, and it showed that with the steroid implants that are placed in the office, that these patients have reduction in nasal polyp size and improvement of nasal congestion and reduced need for sinus surgery. And there's one new class of treatment options that have become recently available, Biologic. And you've probably heard a little bit about it, and so let me talk a little bit in more detail. And so one of the, now with the introduction of biologics, one of the questions that comes up is how do you decide which patient should get the biologic? And so Euphoria was a group of international experts that came together, and they came up with specific criteria on what they think should be met before the use of biologic. And so one of the criteria was that you have to have a presence of nasal polyps. Without the presence of nasal polyps, you shouldn't be getting these biologics. And then if you've had a prior history of sinus surgery, that already kind of puts you in a class saying that you're more likely to have more severe sinus disease with nasal polyps. So you only had to meet 3 of the criteria listed below. Now, if you've not had sinus surgery, then certainly you had to meet one more extra criteria. So you had to meet 4 of the 5 criteria listed below. So type 2 inflammation, need for systemic steroids, significantly impaired quality of life, and you can use different measures such as SNOT-22, the loss of smell, and comorbid asthma. So what are the FDA approved biologics for nasal polyps? So let me go through them. There's 3 of them. One is dupilumab. That was the first one that was approved in June of 2019. And the pivotal studies were Science 24 and Science 52. Omalizumab was the next one that was approved in the following year in December of 2020. And the pivotal study was Polyp 1 and Polyp 2. And then Omalizumab was the one that was approved this year in July, and that was from the Synapse study. And so these are the three biologics that are approved for nasal polyps. So let's go into more details and look at the clinical study. So, in these chronic sinusitis with nasal polyp study, they had to measure two primary endpoints. One was nasal polyp score. And so here is a definition of nasal polyp scores. So 0 is no polyp, 4 is having a polyp completely occluding the nasal cavity. And 1 is within the osteometal complex above the inferior border of the middle turbinate. 2 is below the inferior border of the middle turbinate. And 3 is when it reaches the inferior border of the inferior turbinate. So those are the different nasal polyp scoring systems that they used. Now, the other primary endpoint that patients used in this pivotal studies was nasal congestion. And one of the ways that they measured it was using a score of 0 to 4. So if it was 0, they had no symptoms of congestion. If it was 1, it was mild congestion. 2 is moderate, and 3 is if it's severe. So if you look at the clinical study looking at Dupilumab, you could see on the left table that you look at nasal polyp score and the nasal congestion. And you could see in the Sinus 24, they were given Dupilumab for 6 months and then off it. And so what you could see is for the nasal congestion and the polyp that they had enormous improvement in the nasal polyp score and congestion. And in fact, the nasal polyp between the treatment group and the placebo group was 2 or more between the treatment group and the study group. And in fact, about 50% of the patients in Sinus 24 and 52 had a polyp score greater than 2 from baseline. So that's a pretty impressive change in the nasal polyp score. And you can see that in the Sinus 52, when they were given Dupilumab for the whole 52 months, you could see that there was continued reduction in nasal polyp score and nasal congestion, which is different than Sinus 24. When they stopped it at week 24, you could see that there was recurrence of their polyp score and nasal congestion. And one of the things that's important for patient is use of systemic steroids and the need for systemic steroids and surgery. And you can see that in the treatment group, the group that was given Dupilumab, that there was a sharp difference between the placebo group and treatment group. In fact, the placebo group was more than 3 times likely to need systemic steroids or surgery, which is a big difference between the treatment group and the placebo group. And if you look at the safety data for Dupilumab, you can see that it's fairly safe. And if you look at the most common adverse effect that was noted in the pivotal study, it was nasopharyngitis. And I don't think that is an adverse effect associated with the Dupilumab, but I think that's more of an adverse effect of the disease process, right? So patients with chronic sinusitis with nasal polyps are more likely to get pharyngitis and nasal polyps. I would say the most common IP-related product effect was local site injection. So let's look at the next biologic that I got approved for nasal polyp. And so you see here that Omalizumab, when we look at the change in the polyp score, you see that in Polyp 1 and Polyp 2, the change in the polyp score at week 24 was about 1. So in Dupilumab, it was 2 at week 24 and 52, but in the Omalizumab, it was 1. So it was half that of the Dupilumab. And if you look at the nasal congestion, you could see that the change in the nasal congestion is about a reduction of 1, which is similar to that of the Dupilumab, but maybe a little bit less. But definitely an improvement and the difference between the treatment group and the placebo group for the nasal congestion. And if you look at the safety profile of Omalizumab, well, we know that it's been around for a long time and the safety record has been around, is pretty good. And we see that the 2 most common adverse effect was asthma exacerbation and nasopharyngitis. Again, nasopharyngitis and asthma exacerbation is not so much adverse effect related to omalizumab, but more specifically to the disease process of what's going on with the patient. So let's look at the most recently approved biologic for nasal polyp. This is mepolizumab, the SYNAPSE study. And so what we see here is that the patients that were given mepolizumab, they had improvement in the nasal polyp score, as well as improvement in nasal congestion. And so you see that the median change from the mepolizumab and the placebo group, the median change was 0.7, and actually the mean change is about 1. And so similar to what you saw with the omalizumab group. And as we saw in the dupilumab group, we saw that dupilumab reduced the need for use of systemic steroids and surgery, and we see a similar effect with mepolizumab. So you see that at week 52, that the placebo group was more likely to require revision sinus surgery versus the mepolizumab group. And if you look at the safety profile for mepolizumab, you can see that, again, the most common adverse effect seen in the pivotal study was nasopharyngitis. And again, I don't think that's an adverse effect of mepolizumab, but again, a common adverse effect seen with the disease process. So now we come to deciding, how do we decide to use which biologic? And I think this is where the shared decision-making process is very important, and I think will be helpful in our patients and choosing the different treatment options that are available for our patients with nasal polyps. So the first guideline I want to discuss is the Euphoria Guideline. This was recently published this year and published in JACI. And so as we mentioned earlier, we talked about the definition of uncontrolled and severe nasal polyps. So these are patients, despite medical treatment, still have persistent symptoms, or severe are patients with large nasal polyps greater than nasal polyp score 4, despite medical treatment. So we want to, before you consider giving them a biologic, you want to confirm the diagnosis of uncontrolled severe nasal polyps. Certainly having comorbid disease such as asthma and ARD is important. You want to make sure that these patients have type 2 inflammation or likely have type 2 inflammation, and that can be associated with a type 2 comorbid disease. Certainly you want to have a shared decision-making process and talk to them about the different options and talk about the benefits of each. And you certainly want to talk to them about, the benefits of sinus surgery and biologic for these patients. And then, we want to note that based on that, you can talk to the patient about the different biologics that are available. And these tend to be, and as we discussed earlier, we know that patients with nasal polyposis tend to have comorbid asthma. And if they have nasal polyps and asthma, you want to develop a multi-specialty approach, deciding how to decide, whether or not to give the patient biologic and which biologic to consider. And then once you start them on biologic, you want to make sure that you want to reassess them and see that they have a good response to the biologic. And so based on this guideline, we said that the assessment should be performed at 6 months. And I think it makes sense because if we look at the pivotal studies looking at biologics for nasal polyp, the primary endpoints were all measured at 6 months. So how do we know if a patient had improvement? And so they had to meet one of the different criteria. So these patients had to go from anosmia, having no sense of smell, to some sense of smell. And so if they had one of those symptoms, that would be a response. Another way to decide whether or not they had a response is they had to have an improvement in their nasal congestion, improvement in the polyp score of greater than 1 or more based on nasal endoscopy. And we said that there's also a reduction in the SNOT-22 greater than 8.9, which is the MCID for SNOT-22, or improvement in the VAS score of 2 or more in terms of their overall symptoms. So if that met one of these criteria, they had a response. If they did not, then you would want to talk to them about surgery or choosing another biologic. If they did have a response, then you can talk to them about continuing the treatment for biologic and continuing the biologic. Or if the patient says that their symptoms are improved, but they want to have other treatment options, you can certainly talk to them about giving them systemic steroids or doing sinus surgery with the biologic. And then if they had a response, then you want to continue the biologic and reassess them at 12 months. And then you want to see whether or not they had an adequate response. So our definition of adequate response is that you have to fulfill all these criteria. So the nasal polyp score has to be less than 4, nasal congestion has to be less than 2, so it has to be less than moderate congestion. The VAS score has to be less than 5 out of 10. So the VAS score is a score of 0 to 10, and you want to have a less 4 or less. And the SNOT-22 has to be less than 30. And if they had an adequate response, you can just continue them with a biologic treatment. If they didn't have a response or didn't meet all the criteria, you can certainly talk to them about choosing another biologic or performing sinus surgery. And I think this is a very good guideline on deciding who should get the biologic and whether or not to decide if they had a response to the biologic and continuing the biologic. Now, I think in the US, it was a little bit different because in the US, we have other treatment options that have been approved for nasal polyp. And so this was a multidisciplinary, stepwise approach for the management of nasal polyp. And the reason why this paper was performed is because in the US, there were more treatment options available, and the current Euphoria Guideline did not address all that. And the purpose for performing this paper was basically to recommend optimal treatment sequence for our patients with nasal polyp, improve quality of care, and reduce variation in cost for our patients with nasal polyp. And you can see that the people who were involved in these studies, the experts represented different national societies, such as from the American Rhinologic Society, the American Academy of Otolaryngology, Allergy, the American Academy of Otolaryngology Head and Neck Surgery, the American Academy of Allergy, Asthma, and Immunology, and the American College of Allergy, Asthma, and Immunology. So we had 5 national organizations that had different experts represented in this paper. Now, to summarize this paper, it can be summarized in 2 figures. And so I'm going to start off with the first half. So similar to the Euphoria Guideline, it was important to make sure that these patients have subjective symptoms of nasal polyp, and such as congestion, facial pressure, and such as we talked about. And if you can include a quality of measure, it would be nice. Then not only do you have to have subjective symptoms, but you also have to have objective finding as well. So this was documented on anterior rhinoscopy, nasal endoscopy, or CT scan. Now, if these patients had nasal polyps or chronic sinusitis with nasal polyp, we think that the initial treatment should be nasal steroid spray. And in the US, since this is over the counter, many of our patients who have nasal polyps are already on a treatment of nasal steroid spray. And then we said that the response should be assessed after 4 weeks, after a month. If these patients had improvement with their symptoms, then they can continue with the use of nasal steroid spray. But we know that 80% of these patients on nasal steroid spray with nasal polyps don't get better. And so we know that these are going to be the more severe patients. So this is where we think that it's important to try to, look at endotyping these patients of all the clinical studies that are available. So these are allergy testing to try to figure out what's causing the polyp, aspirin challenge if there's a history of aspirin intolerance, CBC with differential, looking at blood eosinophils, as well as total IgEs or a specific IgE. And by using these tests, we kind of get a better idea of what's causing the nasal polyps and how severe the patient may be. Now, if they fail the typical nasal steroid spray, certainly we could talk about alternative delivery of topical steroids. And since in this paper, since we were talking mostly about FDA-approved products, we talked about exhalation delivery system using fluticasone, as we talked about earlier. And certainly, short bursts of systemic steroids is an option. And if they fail this non-traditional delivery of topical steroids using the exhalation delivery device, we say that you have to escalate the treatment. And what does that mean? So when we say we have to escalate treatment, we have to decide, what do we do next after they fail a non-traditional delivery of topical steroids? And what the experts agreed on is that majority of these patients should undergo sinus surgery. So these are patients who have never had sinus surgery, have failed topical steroids, and so if they fail that, it makes sense to do sinus surgery on majority of these patients. Now, not all patients should undergo sinus surgery. There are some patients who cannot undergo sinus surgery, for various reasons. There are some patients who just don't want to do sinus surgery. And there are other patients with nasal polyps that have comorbid asthma that's poorly controlled. So someone like our Bob patient, so even though he's on high ICS and LABA, the patient's asthma is still poorly controlled. So this is the patient that would maybe benefit from the use of biologic first before doing sinus surgery. But in general, our experts felt that majority of these patients should undergo sinus surgery if they've never had sinus surgery before. And then after the medical treatment, give them some type of postoperative medical treatment to prevent the polyps from coming back. And I would say a lot of the patients who have nasal polyps undergo sinus surgery with medical treatment afterwards will likely do well. But there are some of these patients who will not, and they will have recurrence of the nasal polyp. And if they've had sinus surgery, good, appropriate medical treatment afterwards, and still have recurrence of nasal polyp, these are the more severe patients with nasal polyp. And I think this is where it's important to have a comprehensive multi-specialty approach to these patients. And when we're talking to our patients with nasal polyps, we need to have a shared decision-making process, because in the US, there are several FDA-approved treatment options. And we talk about some of the other treatment options that are commonly accepted. So we have Biologic, revision sinus surgery, aspirin desensitization in patients with ARD, steroid sinus implants, and short bursts of steroids. So these are all treatment options that we have discussed in the past. So when we talk about shared decision-making process, what does that exactly mean? And so what that means is, we need to provide information to our patients and talk to them about, what is it? What are the advantages of using these treatment options? What are the disadvantages? And what are the costs? And so, when we talk about costs, we're not talking about costs to the healthcare system. We're talking about cost to the patient. So we know that intranasal steroid spray, the cost is very low. The exhalation delivery system is a little bit higher. Surgery is higher. The steroid implants is also higher. And then also the biologics are higher. So, we want to talk to them about all these treatment options and inform them so that they can make a informed decision. So basically what we're doing is we're trying to inform the patient so they can decide what is best for them. Now, the shared decision-making tool is available on both the American Rhinologic website as well as the American College of Allergy, Asthma, and Immunology website. So you can download the paper tool, or I think there's an electronic version available on the American College of Allergy and Asthma website. So then let's go back to our patient, Bob. So we know that he has uncontrolled severe chronic sinusitis with nasal polyps and comorbid asthma because he's been on nasal steroid sprays and irrigations, and despite that is having persistent symptoms. And in fact, his asthma is not well controlled with ICS and LABA. So here we're going to present to him the different treatment options. And based on the Euphoria Guideline, since he has uncontrolled severe nasal polyps, we would talk to him about the two treatment options that are available, which is endoscopic sinus surgery or biologics. And if we look at the biologics that are available in the US, we know that dupilumab was approved first, followed by omalizumab and mepolizumab. And when we're talking to the patient about the different options, these two options that we're talking about, we want to tell him, that sinus surgery, it will require him to undergo general anesthesia and require some time away from work. With the use of dupilumab, we know that it's been the first approved treatment for nasal polyps, and the dosing is every other week. Omalizumab has been around for a long time for the treatment of asthma, but was approved second after dupilumab. And the dosing is based on the total IgE and the weight of the patient, and therefore is given every 2 to 4 weeks. Mepolizumab, which was most recently approved for nasal polyp, the dosing is every 4 weeks. So in summary, we know that chronic sinusitis with nasal polyp is very common, and of all the patients with chronic sinusitis, it accounts for about 20%, 20 to 25%. We know that our patients with nasal polyps tend to have other type 2 comorbid disease such as asthma, allergic rhinitis, and ARD. And we know that chronic sinusitis is a type 2 driven inflammation. And we know that the primary type 2 cytokines are IL-4, IL-5, and IL-13. And those are the biologics that are targeted by the biologics that are approved for nasal polyps. And we know that in patients with chronic sinusitis with nasal polyp, with saline irrigation, nasal steroid spray, it's a high failure rate, about 80%. And so therefore, we have to consider other treatment options, including sinus surgery. And even with sinus surgery and medical treatment, it can be effective, but the recurrence rate of nasal polyps is high. And that's why there was a room for improvement. And that's where I think biologic plays a very important role. And we know that there are 3 biologics that have been approved for chronic sinusitis with nasal polyp. And I think those are decisions that where a shared decision-making tool should come into play. So because you want to look at the patient's goal, dosing preference, and coverage by the insurance company. So now that we're done, let's take a post-test question. So question number 1 is, what are the primary cytokines involved in type 2 inflammation, which is the most common endotype seen in our patients with nasal polyp? Is it interferon gamma and IL-12? Is it TNF and IL-6? Is it IL-4, IL-13, and IL-5? Or is it IL-17 and IL-2? So please make your choice and select the submit button. So the next question is, which biologic showed an improvement in a nasal polyp score of 2 or more in close to half the patients, and half the nasal polyp patients at week 24 and week 52? Was it benralizumab, dupilumab, mepolizumab, or omalizumab? So please make your choice and click the submit button. So let's go to our next question. So which is the most commonly observed treatment adverse effect during the clinical trials of all the biologics for nasal polyps? So was the most common adverse effect epistaxis, injection site reaction, nasopharyngitis, or abdominal pain? Okay, so let's go to the next question. So Mr. Brown, he's a 42-year-old patient with severe nasal polyps. So that means the polyp score is greater than 4. And he says that after sinus surgery, it came back within a 12-month period. You suspect that he has nasal polyp and that he has type 2 inflammation that's causing the polyps to regrow back, which makes sense. And so, based on the disease scoring system, there's some improvement. But based on the Euphoria criteria, if the patient didn't have adequate response, what would the Euphoria guideline recommend? So, one would it tell them to have return of medical management and short course of systemic steroids? Would it be the choice between biologic and revision sinus surgery? Will it be exhalation delivery system with fluticasone? Or would it be the use of steroid sinus implant? So please make your choice and click submit button. So if the patient didn't have adequate response with medical treatment, what would the Euphoria recommend? And so this is our last question. So Mr. Brown, feeling discouraged and knows that the pop will grow back even after sinus surgery, he's wondering whether or not he should do sinus surgery again and the downtime that's associated with sinus surgery. And so this is where I think the shared decision-making process is very important. So when we say a shared decision-making process, what does that, how is that best defined? So one, is it to advise him to consider sinus surgery because 30% of patients do require repeat surgery? Is it to tell him that the guidelines would ask him to decide between two options? Is it to give information of all the available biologics and ask him to choose one? Or is it to let him know all the therapeutic options and talk about the pros and cons of each? So please select your choice and select submit. So great, thank you very much. And so now is our time for Q&A. And if there's any questions that you would like to submit, please submit your questions. So there was one question that came in. So type 3 inflammation was covered a little bit, and we know that it's mostly driven by IL-17 and IL-22. But how do we recognize this endotype in patients, in our patients with nasal polyp? That is a very sophisticated question. So thank you for that question. As we talked about, type 2 inflammation can be easily defined, and I think it's the most well defined in our patients with chronic sinusitis. And in fact, chronic sinusitis with nasal polyp tend to be driven by type 2. And the reason why we know that is because we can look at the phenotype. We can look at the type 2 phenotypic comorbid disease such as asthma and allergic rhinitis and ARD. And so by having these comorbid disease, we can kind of indirectly infer that this patient has type 2 inflammation. Type 3 inflammation is a little bit harder. Measuring, unless you have a lab where you can measure IL-17 and IL-22, it's much harder to detect unless you have a lab. And there aren't specific type 3 comorbid disease that stand out. And I would say type 1 inflammation and type 1 inflammation and type 3 inflammation are not well defined in chronic sinusitis. And so I think it's much harder to do that. I know in our labs, we tried to detect IL-17 using flow cytometry, and it was very difficult. We had a hard time. So we ended up finding them with immunochemistry. And so we were able to detect that. And we know that IL-17, there's 6 different subgroups of IL-17, and some of them can even be seen in type 2 inflammation. So I think that question is a very sophisticated question, and I think is a very hard question to kind of answer. And I think I don't know how to answer that well, and I think it's hard to be able to detect that endotype without specifically measuring IL-17 in the tissue, the nasal polyp tissue. There's another question that came in. Is sinus surgery truly one treatment options, or can repeat sinus surgery be recommended? And I would say absolutely the answer is yes. Sinus surgery, as we discussed earlier, if people have nasal polyps and undergo traditional treatment with saline irrigation, steroid spray, and they're not getting better, you want to consider alternate treatment option, steroid delivery. And if they fail that, I do believe that sinus surgery is a very good option. Certainly, biologic is also another option, but I think for majority of these patients, sinus surgery is an option. But with the sinus surgery and you give them topical steroids and the polyps start coming back, I think repeat sinus surgery really is an option. But patients undergo this this process of surgery fatigue. And what I mean by that is that if patients have sinus surgery and you do it again and again, a lot of these patients get disappointed. And so for me, I work at a tertiary rhinology center. 80% of my patients are referred to me by other otolaryngologists. These patients that come in are the patients like Bob. They've had polyps for a long period of time. They undergo an average of 2.3 sinus surgery before they come and see me. And then, if the polyps are very big and I tell them, the medical treatments may not work and we need to do sinus surgery again, a lot of these patients are very discouraged and they say, a very common question is like, how do I know your sinus surgery is any different than the surgeries that we've had in the past? And, the way I answer that question is, we have to figure out what's causing the nasal polyp first. And after we understand that, and if we do surgery and give more personalized treatment options, we can prevent the polyps from coming back. And so by doing that, they do finally agree to do sinus surgery again. But a lot of patients don't want to do sinus surgery again. And that's why I think biologic is a very valid option for these patients, or even the steroid implants that we talked about is another option. And so I don't think sinus surgery, if you did it once, you can't do it again. You can certainly do it again, but again, I think that's kind of where that shared decision-making process is so important, and you got to really incorporate that to the patient, because then and decide, is that something that the patient wants to do? And I think the days of old when we would tell patients what to do are kind of gone. So thank you for those great questions. So it looks like there are no more questions, and thank you for the nice comment. So I just want to thank the audience for attending our webinar. You can find additional resource and information related to chronic sinusitis with a website on this website, the integrityce.com/CRS with nasal polyp resource. You will now be redirected to the evaluation, or you can claim your CME credits at the website below, integrityce.com/CRS with nasal polyp post-eval 6. So thank you very much for attending our webinar, and